Research can be exciting, so I'm going to try and be as exciting as I can be up here. Today I want to talk about the concept of if you're not counted, you don't count. It's a very harsh statement. What I'm really talking about is the need for us to matter, to count. From a personal perspective, my name is Notisha Massaquoi. I immigrated to Canada with my family from Sierra Leone, and personally understand the need to matter, or the need to count, if we look at what's happening in Sierra Leone today. And as a country, we've been asking for an Ebola vaccine and the trials to start for over a year. And I think we all work with people who we want to matter. We want them to count. I work at Women's Health and Women's Hands Community Health Center, and our primary client population are racialized women, newcomers from Africa, the Caribbean, Latin America, and South Asia. And the purpose of our work is to provide primary health care and to ensure that their lives matter, that they actually count. And I've come to understand the need for us to engage in research and to conduct research, and more so in an organization such as mine that is completely dominated by extremely powerful women, the need to control the research. Just recently, we received something called the Provincial Practice Profile. It's a wonderful tool. It's a wonderful document that researchers have developed that allows us as community health centers to look at the complexity of the clients that we serve, specifically in our community health center. It tells us the breakdown of their socio-demographic status. It tells us what services they've used in our healthcare system. It tracks all of your movement through the healthcare services. It can tell you the complexity of care and requirements of the clients that you serve as a community health center. We were extremely excited to get this information. When we opened our document, there was a note on our profile that said 50% of your clients do not count. When we called to find out why 50% of our clients were not included in this documentation, we realized it's the clients who are uninsured, the clients who are failed refugee claimants, those who got caught in the middle of the IFH kerfuffle, and it amounted to 50% of our clients not counting or not mattering. The other thing that concerned us as a community health center was the understanding that our complexity determined how many clients we were now going to be required to see per provider. And it was solely based on 50% of my most resourced clients, my clients who had access to the most amount of services, my healthiest clients. 50% that were not counted are the most marginalized in our system. And it really made us understand, and this is just happening recently, that the work that we do in terms of research and controlling research matters. It is extremely important that we understand research as well as service providers, and not just accept these kinds of reports as something that I now have to do because my funder has determined it for me. And as an organization, we've rejected our practice profile. We refuse to use those stats, and we insist that they figure out a way to make the 50% that are missing matter. I also want us to emphasize today or understand that if we don't do our own counting, it's done for us. And what ends up happening often is that our lives get interpreted for us. And the example that I use is the whole notion of, I'm going to talk a lot about healthcare because that's the business I'm in, that your health care is up to you. You receiving good health care, it's really up to you. It's an individual, and your efforts to find a good doctor, your efforts to get to the service, that's what matters. And if you look at the research around immigrant populations and their utilization of healthcare services, the research focuses on our underutilization It focuses on the notion that if there's enough public education that we will understand and get to the service. It really focuses on interpretation. So it's because our clients don't speak English, that's why they don't understand what's happening, and that's why they're not accessing services appropriately. And also our cultural preferences. We don't choose to go to healthcare services, or we choose different types of alternative practices outside of the mainstream. That's the interpretation that we get when we are not actually doing the counting. It would look very different, I think, if in our sector we were doing the research and interpreting why we're missing, why we're not accessing healthcare services. So I really want to emphasize that it's not just about not being counted, it's also about who does the counting and why we need to take some leadership in ensuring that research is interpreted to actually make sure our clients matter. Next slide, please. Also, when we're not doing the interpreting and counting, critical issues often get lost. So the things that are crucial for you to do your work and crucial in terms of your clients being successful. A lot of the research focuses on the negative side of, it doesn't focus on the negative side of immigration. It's all about the positives, which is important, yes, but we also want to look at what are some of the challenges that we're having. We also want to move past the notion of the healthy immigrant effect. We have lots of research on the healthy immigrant effect, and I know people know a lot about it. But how do we move past that when we're looking at health outcomes currently for our communities that are actually so much less than the Canadian population? Yes, we're screening people during the immigration process to ensure that they're healthy when they get here, but how am I actually using the research to ensure that they stay healthy while they're here? The immigration discussion often doesn't focus on women when looking at migration and economic development, and there's very little information on individuals who are here without status. So it's very important to understand what issues get left out of research when we're not controlling the research. Research is often used to create unrepresentative narratives or descriptions or stereotypes of who we are as immigrant populations. So you have things like, the next slide, please, the needy dependent immigrant, if we look at all of the research that's put out, or the subtext portrays us as needy and dependent. Very little is known about immigrant women's strengths and their successful strategies of how they're coping, how they're surviving. I've been in Canada for almost 30 years. I've done quite well. That would be an interesting story to follow, I think. I always talk about the client that I had many, many years ago, a woman from Somalia who had survived war in Somalia, lost her husband, got her 5 children to Kenya, survived refugee camps in Kenya, got the 5 children to England, had a failed refugee claim in England, got the 5 children safely from England to Toronto and sitting in my office. That's not a needy, dependent woman. Right? That's an enormous amount of strength that I will never be able to articulate and doesn't show up in the types of research that I read about in terms of the immigrant populations we work with. The whole notion that Canada is a better place is the type of research that is pushed by our funders, and we understand why. And for some people, Canada does not become a better place. It's a drop in status, it's a drop in economics. I mean, we can go on. We all know this sitting in this room. But the research doesn't reflect the realities of the work that we do and what we see and the stories that we hear. I think we also need to focus on reframing research as an intervention strategy. How many people are going to tell me I don't have enough time to engage in research? It's not rhetorical. You can raise your hands. We do a lot. We're busy. We have an enormous amount of work that we have to engage in. But we have to start looking at research as an intervention strategy. It's one of the tools that you're using in your organization to engage your clients and to develop better practices. Research from our perspective at Women's Health and Women's Hands allows us to gain strength from the collective action in terms of the research that we do. It helps us develop new knowledge, new skills. It helps us to share that new knowledge and skills across our sector. And it also helps us establish new sorts of supports and networks. So looking at researchers in the academic institutions as a new network of supports that we can gain and that we can work together to build for our sector. In terms of women's health and women's hands specifically, we began engaging in research in 1999. And it's not something we wanted to do necessarily, but what we were finding at that time was that immigrant women, and especially racialized women, had the highest rates of all the chronic illnesses across the city. Latin American women and Caribbean women had the highest rates of low birth weight babies. South Asian women had the highest rates of diabetes. African and Caribbean women had 90% of all HIV positive babies born in the city in that year. We did not have any research that talked about why and what the health issues were for these populations, and how could we develop services, programs that would address these things without this type of scientific knowledge. And so we began our path of recruiting researchers to come and work with us, which didn't work. We couldn't find people who were willing or interested in doing this type of research. And so we began to do it ourselves. We found people that could help us and train us to start doing this research on our own. And we began the development of our research program at Women's Health and Women's Hands. And we have 3 objectives: to build scientific knowledge on the health of racialized women, to foster autonomy, self-determination, and leadership skills of racialized women, and to generate knowledge and evidence to inform and support Women's Health and Women's Hands strategic plan, programs, and services. Those are our objectives. Since that time, many researchers come to want to work with us. We're overwhelmed with the requests. If your research does not reflect these 3 objectives, we will not be working with you. So if our clients are not going to prosper, if our organization is not going to gain strength from the study that you're proposing, we're not going to proceed. We also developed a method of prioritizing what were the research studies that would be most impactful for the women that we work with. We conducted surveys with our staff. First, that was the needs assessment that was done to ensure that we understood what their needs were. We also did an inventory of what their research skills were and things that people wanted to learn so that we could do training, education sessions with the staff on how to do research while prioritizing what they felt the main issues were. We conducted surveys with our clients. We did interviews and focus groups to figure out what they would like us to research. And then we did a survey of all of the academic partners and institutions who were interested in working with us. From that process, we only chose the studies that intersected with all 3 groups. And today we currently have 25 studies that are housed at Women's Health and Women's Hands. Very quickly, the other thing that I really want to emphasize is the notion that I think Dr. Bauder already talked about, which is the need for outcomes that are relevant to the work that you're doing. The academic outcomes are about tenure, publication, job advancement. Those are not the outcomes that we are interested in. The studies are important, but not necessarily the publications in academic journals. An example of a beautiful outcome that came about from a study that we conducted, which tracked or followed 15 newcomers in their first year in Canada. We wanted to know what was the experience of settling in Canada. And we met with 15 women every week to figure out that experience. The outcome for that project was a book of poetry that the women published. So they asked the university, they weren't interested in the academic publication, but a publication that could be used in ESL classes. The interviews that we conducted with the women were turned into poetry and translated so that women that were just learning English could use this as a tool. The poetry talked about their experience. You really could understand what they were feeling in that first year. Another type of outcome that came out of an HIV study where we were looking at African and Caribbean women and their experiences of living with HIV, was a documentary where we once again followed their lives. The documentary took the themes from the research and we interviewed women about their experiences living with HIV. The goal was that this film could be shown to service providers so you could better serve the women that were living with HIV. And that documentary has been screened over 500 times and 10,000 copies have been distributed globally. We couldn't achieve that kind of outreach with an academic journal. We keep going. We also look at research that is predictive. So we just don't want to do research that focuses on what our problems are presently, but how do we provide solutions to those problems? HIV was one of our biggest issues, and we collaborated with U of T to develop a study that would prepare women for an HIV vaccine. So let's think in the future. What we found out was that we have as communities issues with vaccines. So once the vaccine arrives, I'm not just going to line up to take an HIV vaccine. So the study looks at what would be needed to prepare communities for such a medical technology to be in place. And finally, all of our research ends in what we call a knowledge translation forum where researchers, the community, service providers get together, they discuss the potential outcomes, the interpretation of it, and make decisions on it, the research, before the researchers publish. So we actually vet it before the publication starts so that we're all in agreement with the results and how those things get translated and portrayed to the community. I'm going to wrap up very quickly. Priorities. We need to engage in research. Our sector must direct the building of foundational research for the communities that we serve. We have to develop our own unique analysis frameworks, not the ones that are given to us by the researchers, but the ones that make sense for the realities of our lives. We must ensure that our research not only empowers communities, but influences service delivery and policy. And we must share research resources, skills, and expertise across the sector. Some of us have more expertise and knowledge than others. We need to share that across the sector so it's equally shared. And my final slide is just around the academic and community-based bridging when working with academics. I probably should have said this one first, but I think my previous speakers have already spoken to it. We have to understand that our researchers must be held accountable to the communities that we serve. We are the custodians of the information that our clients are bringing. We have an obligation to ensure that the researchers we work with feel the same way about our communities. We have to understand the intent versus the goal and objectives. If the intent of the researcher is academic advancement, that's not who I want to work with. The intent must be to ensure that our clients' lives matter through the research. We also have to understand that the subject or our clients are the experts in their lives, not the researchers, and that as researchers, we also belong to communities. So I try to work with researchers who belong to the communities that I'm working with. And if you don't belong to the community, understanding your role within that community or the type of privilege that you might bring if you're not a member of a marginalized population. Understanding that taking from the community requires that you give back. You have access to the clients. You are responsible for ensuring their safety within the research. And without the service providers and the agencies, the research can't happen. So it's understanding the power that you have within that to actually control the type of research that's happening, the type of research that's being done, and to understand that the research can't happen unless it's with us and by us. Thank you.